Quality Improvement in the Clinic, Diabetes Mellitus. This module was developed for the Michigan Medicine Internal Medicine Residency Program by Mandy Cox, Ambulatory Lead for the Patient Safety and Quality Improvement Learning Program, and Katie Gribb of the Internal Medicine Quality Improvement Team. In today's session, we will first review population health and panel management concepts, which were introduced in the 2019 session for Quality Improvement in the Clinic. An update will be provided regarding geriatric pneumococcal vaccination, which was the focus measure for 2019. Then we will study how quality improvement methods can be used to explore challenges and potential solutions for managing patients with diabetes. New for 2020, we would like to have you all apply one specific action to your clinic encounters with diabetic patients. And in a few months, we will connect to see if this work is helping to improve diabetes care in your population. After the video, there will be time to review your patient panels and performance data, discuss the analysis of diabetes care as presented here, and then implement an action plan for improvement. Let's start with a review of population health and panel management. For healthcare, a population is defined as a panel of patients who are assigned to one provider, or on a broader level, population could refer to all the patients in one clinic or the health system as a whole. Data relating to the health of the population is a starting point for identifying problems that need extra attention. Population-based care allows healthcare providers and the systems in which they work to be proactive in identifying and addressing patients' preventive and chronic care needs. Panel management refers to caring for the patient population overall, rather than only those patients who happen to come into the office for appointments. In populations that are generally healthy, this approach can help prevent or delay chronic illness. In populations with chronic diseases, tracking and addressing gaps in care ensures that the patients receive what they need to enjoy longer and healthier lives. Population-based healthcare starts with a registry of patients assigned to a provider, clinic, or health system. Clinical guidelines are often used to define goals of care. Reports on patients meeting various criteria are used to identify where care gaps exist, or fallouts if you work at the VA. System workflows, including best practice advisories and standing orders, or reminders at the VA, can be developed that make it easier to identify and deliver needed services. For actions that don't require complicated medical decision-making, these measures can allow care team members to complete the work without immediate input from the PCP, increasing efficiency. All members of the care team can be part of these efforts. Some clinics have dedicated panel managers, where others may use nursing staff and medical assistants. Finally, panel management involves two basic work types. In-reach refers to offering patients preventive services during their visit when feasible. Outreach involves contacting patients between visits to offer needed services or arrange an overdue appointment. Several questions commonly arise for individual physicians when they are doing the work of population health. Which patients are assigned to me? Who on my panel of patients has gaps in their care? Some patients have so many gaps it can be challenging to address them all. So how do I know which issues to address during the visit and which can be handled by other members of the care team or deferred to a future visit? And how does the system keep track of patients who have been offered services previously? For Michigan Medicine registries, patients are attributed to the clinic and provider seen most often, not just the PCP listed in the chart. Specific criteria are applied to determine which patients are tracked for any given measure, such as demographic factors, lab results, vital signs, and visit or problem list diagnoses. Clinics typically outline expectations for managing care gaps at various visit types. Whenever possible, standing orders allow the care team to address some of the gaps without immediate input from the physician. If you are not sure how things are done at your clinic, ask your preceptor to review this with you after the video. Sometimes the physician and care team have attempted to address a care gap, but the service was not completed. This might reflect patient factors such as cost concerns, transportation, or the reluctance to obtain certain services. Recognizing this, the goals for various metrics are never set to 100%. With a team-based approach, we can accomplish the work of population health more effectively. Quality improvement methods can be used to address clinical problems in a systematic manner by analyzing the possible reasons for not meeting a target on a given metric, applying a change to the process for that condition, and then reflecting on whether the change led to the desired improvement. Ultimately, by applying QI methods in primary care, we hope to achieve what is referred to as the quadruple aim, or better patient outcomes while improving the patient's experience, reducing cost, and returning joy and work to members of the care team. Now we will take a moment to discuss geriatric pneumococcal vaccination, which was the 2019 topic for quality improvement in the continuity clinics. After the topic was introduced in the March 2019 teaching time, the guideline for these immunizations was updated by the CDC. A scheduled review of vaccine effectiveness showed less benefit of the PCV13 than expected in patients over 65. However, many of our patients will still benefit from receiving both PCV13 and PPSV23. Engage in shared decision-making with your patients, and if the decision is made to go ahead with both vaccinations, remember to administer the PCV13 first. Be aware that until an update can occur, the best practice advisory in my chart reflects the prior recommendations. In the next several slides, we will think about how care for patients with diabetes mellitus can be improved in your continuity clinics. New for 2020, a simple intervention will be provided to assist you in helping patients achieve their target A1C values. Progress reports will be shared periodically with updated site-level data. To help continually improve this measure, additional cycles of improvement will be considered and communicated as the year progresses. The graphic shown here demonstrates the high prevalence and increasing burden of diabetes. Diabetes is a common disease with high rates of complications, including risk for early death. Patients with A1C values over 8% are at especially high risk for adverse health outcomes. These effects can be mitigated by improving glycemic control in affected individuals, particularly in younger patients. Michigan Medicine has chosen as an institutional priority for 2020 to focus on reducing the number of patients with A1C values over 8%. At the VA, the target is currently 8.5%. This graphic shows how the University of Michigan Medical Group, or UMMG, is performing at the health system level for the ABC metrics of diabetes care. Take a look at your site-level data at the end of this module and notice where things are going well and where there is room for improvement. Multiple workflows for both in-reach and outreach are in place to assist providers in managing this condition and vary across practice locations. Talk about expectations for management of the ABCs of diabetes at your site. This graph shows the percentage by age group of Michigan Medicine patients with diabetes who had an A1C in the target range of under 8% as of September 2019. You can see that the proportion of patients out of range is higher in younger age groups who could benefit the most from improving glycemic control over their lifespan. The younger patients are more likely to be type 1 diabetics, the majority of whom are primarily managed by endocrinologists. In those patients, the PCP clinic may not routinely adjust insulin, but can facilitate their care, address some ABC measures as needed, and manage other acute and chronic conditions. For purposes of performance tracking, these patients will still be reflected in the PCP's data, as well as the endocrinologist if they are at Michigan Medicine. If your clinic is at the VA, take a look at the institutional metrics after the video. Now that we have a better idea of the scope of the problem, we need to understand how the work of diabetes care is being done currently. Shown here is a flowchart for diabetes care as it is typically managed at the Brighton Health Center. Central to diabetes care is the PCP visit. If the A1C is noted to be out of range, closer follow-up can be arranged through more frequent office visits, portal or phone messages. Many pathways and resources are available, including on-site support from a doctor of pharmacy who can facilitate medication and lifestyle management for type 2 diabetics. Panel managers periodically provide outreach to patients who are overdue for A1C checks or office visits. After the video, take a moment to review the current workflows for diabetes care at your clinic. Now that we have thought about the background, current performance, and workflows for diabetes care, we should refine our way of communicating the problem as we see it, and then decide on a target for which we can aim over the next year. In QI methodology, a good problem statement identifies a gap between what is actually happening in the current situation and a future improved state. It is important to set a goal that is attainable but still clinically meaningful. In the case of diabetes care, it would not be reasonable to set a goal of improving the rate of A1Cs over 8% in your population to 0. On the flip side, it would not likely be clinically relevant for the majority of patients if your goal was to improve A1C values by just 0.1 or 0.2%. Keeping the timeline in mind is also important. It may be reasonable to achieve a 10% reduction in patients with A1Cs over 8% in 6 to 12 months, but unlikely to succeed if the goal is to reach that target in just a few months. Try to set a SMART goal. These are specific, measurable, achievable, relevant, and time-bound. Here is a suggestion for a problem statement and goal for the proportion of diabetes patients with A1Cs below the target of 8%. These reflect the target for Michigan Medicine patients at the institution level. For a problem as complex as diabetes, where it can take a long time to see the effects of any given intervention, it may also help to describe a narrower aspect of the problem, such as at the clinic or individual level. This allows for incremental improvements that can be more readily tracked. Once you have defined the problem and set a goal, it can be difficult to refrain from jumping right into the first solution you think of. Using QI methods allows you to take a deeper look at the problem by performing a root cause analysis. This helps you identify multiple targets for improvement that you can prioritize based on their impact and effort in achieving your goal. Start by taking the first cause you identify and ask why repeatedly until no further ideas are generated. Then do the same for another possible cause. In this manner, you will avoid narrowing the focus of potential solutions too soon, possibly missing a key factor. This process is referred to as the 5 whys. Shown here is a draft analysis of our problem of patients with diabetes mellitus having A1C over 8%. Several possible reasons are listed, and one shows how a 5 why analysis can lead you to a more nuanced understanding of the root causes. If time allows after the video, talk about other factors that could be contributing to the problem at the system, provider, or patient levels. In QI terms, a recommendation or countermeasure is one idea for a change that could move you closer to your goal. Ideally, you select and apply one countermeasure for a certain period of time, then reflect on whether the results are as you had expected before applying a different countermeasure, and so on. These are called Plan, Do, Study, Act cycles, or PDSA. Projects commonly go through multiple cycles of PDSA before being completed. Listed here are a few ideas for possible countermeasures. You may think of other ideas that can be shared after the video. Given that this module is directed toward resident trainees across sites with varying workflows, a measure that educates and guides you as the PCP is a logical starting point. Details are being refined at the time of this recording and will be shared in the facilitator's guide. Here is a chart showing site-level data. We will provide updates as you gain skills in managing diabetes in the clinic over time. In a few months, we will provide another straightforward intervention to aim for continued improvements. A formal check-in will occur during September teaching time. Note that because this is an institutional focus measure, interventions at the level of the health system are likely to be implemented as well, such as new BPAs. If so, we will layer those onto our work at the residency level as additional PDSA cycles and make note of that in the tracking. The key point is that we are all working together to improve care for our diabetic patient population in a complex system. The information and thought process described in the previous slides can be summarized onto a single document, commonly referred to as an A3 worksheet. An A3 is a way to format your problem-solving efforts to better understand the situation and potential solutions, and more readily communicate your ideas for improvement to others. It is not intended to be the final analysis, but can be considered a living document to be updated as new information is considered. Copies of this drafted analysis for diabetes control are available for you to review and discuss as time allows. Panel management is a proactive, team-based approach to population health. Applying quality improvement methodology in the clinic allows the team to systematically address the needs of the population. Together, we can have an impact through measurable improvements. Please take a moment to complete a short survey on today's module. With your input, we hope to continually improve the delivery of further curricula for quality improvement in the ambulatory setting. Thank you.